respected faculty of the pharmacology of Rangaraya Medical College, and dear postgraduates. At the outset, I thank the pharmacology department for giving me the opportunity to speak on the complications of the diabetes. So you all know that diabetes is a very common disease in the society. Every day we are seeing a lot of the cases of the diabetes in India. The numbers of the diabetic population in India is increasing in a tsunami proportion. Now we are the #1 country in the world with the highest number of the diabetics, surpassed the China. And the diabetic capital of the world is the India. You name any type of the diabetes, they are there in India. Whether the type 1 diabetes or type 1.5 diabetes, that is LADA, or the type 2 diabetes, that is the obesity or overweight associated diabetes, or type 3 diabetes, type 4 diabetes, type 5 diabetes, you name any diabetes, they are there in the Indian population. And fortunately, the disease with very, very least symptoms is the diabetes. You know several symptoms of the diabetes. And if you ask me a leading question that what is the most common symptom of the diabetes, no symptom at all. That means 80 to 90% of the diabetic individuals, they are living in the society without any symptoms. So asymptomatic diabetes is so common in Indian population. Then why should we treat an asymptomatic fellow? Because if left untreated, it leads to a lot of the complications. So that is the beginning of our lecture, and I am going to tell you what are all the complications of the diabetes if left untreated. So by this time you know what you mean by the diabetes. The diabetes is nothing but the chronic hyperglycemia. When the fasting blood sugar is more than 126, post-planned blood sugar is more than 200, random blood sugar more than 200, HbA1c more than 6.5. Any one of these 4 criteria is sufficient to diagnose a fellow as a diabetic. And unfortunately in India, the 50% of the diabetics, they are not diagnosed at all. They are living with the diabetes without knowing that they are having hyperglycemia. And out of the 50% of the population who know that they have the diabetes, but unfortunately, again 50% of the individual, they are not on treatment at all because they are asymptomatic. And those people who are on treatment, again, a lot of the people, they are not on target. Target means you have to keep the fasting blood sugar around 100, post-planned blood sugar around 150, and HbA1c around 6.5. So finally, in India, only 9.4% of the diabetics are living with your targets. So that means a lot to be done for the diabetics of Indian population to reach their blood sugars as the euglycemic levels and to avoid the complications. So now you begin the complications, they can be divided into several complications. You have the acute complications, you have the chronic complications, and in India, not only the acute and the chronic complications, but also the infections in the diabetes individuals. Whether it is streptococci or other bacteria or the viral or the fungal. So these infections are so common in Indian population like your carbuncles or mycormucosis or rhinocerebral cerebroactomycosis, etc. These are all the life-threatening infections we often see in the diabetic individuals. And as far as the acute complications are concerned, you have the hypoglycemia, that is the most common complication. You have the acute complications, most important is the hypoglycemia. So that is a very, very important and very dangerous and life-threatening complication in the diabetic individuals is the hypoglycemia. Severe hypoglycemia is almost close to the death, and if time permits, I will tell you something about the hypoglycemia. And as far as the acute metabolic complications, you have HSS and you have the DKA. So DKA is the diabetic ketoacidosis, HS is hyperglycemic hyperosmolar states. And coming to the chronic complications, they are divided into 2 groups, micro and the macrovascular. So the microvascular complications are the 3. You have the neuropathy, you have the nephropathy, and the retinopathy. And the macrovascular complications are again the 3. You have the ischemic heart disease, you have the cerebrovascular disease, and you have the peripheral vascular disease. So the microvascular damage is otherwise known as the atherosclerotic cardiovascular disease. Right now, Dr. Kiran has told everything about the metabolic syndrome. So what you mean by the atherosclerotic cardiovascular disease? Unfortunately, again in India, a lot of the people are dying prematurely at the age of 30 plus or 40 plus with this atherosclerotic cardiovascular disease. And one of the important reasons is undiagnosed diabetes, undiagnosed hypertension, more and more smoking, overweight, obesity, sleeplessness, and of course, heavy smoking and alcoholism. So you have to avoid these things. So definitely these people will live for the longer period. See the macrovascular disease, I told you the coronary artery disease, individuals with diabetes have 2 to 4 times higher risk of the coronary artery disease. Peripheral vascular disease again higher risk in the diabetic individuals. Stroke or cerebral vascular disease again higher risk in the diabetic individuals. So this is the main cause of the mortality in the diabetes. If you ask me the leading question, what is the most important cause of death in the diabetes? Most common cause of the death in diabetes is myocardial infarction. So a lot of the people with diabetes, you have to respect the vessels, you have to respect the heart, you have to respect the brain and the peripheral vascular system. See, the macrovascular disease is the multifactorial. So I have to control all these things to avoid the cardiac deaths, to avoid the brain death. So you have the hypercholesterolemia. So that means all the cholesterol, not only your cholesterol, serum cholesterol, but also your LDL, your HDL, your triglycerides, non-HDLs, etc. Smoking in any form, whether it's a BD or cigarette or cigar or ganja, etc. So definitely it should be abandoned. Hypertension, yes, it can be divided into 3 groups, stage 1, stage 2, stage 3. Even the stage 1 hypertension is a big killer provided if the patient is a diabetic. Not only the hypertension, even the pre-hypertension is a big killer in a diabetic individuals. So in all the diabetic individuals, you need to keep the blood pressure as close to the normal as possible, that is 120 by 80, if not 130 by 85. So diabetes, I told you everything about the numbers of the diabetes. We have to adjust the blood sugars to reach your euglycemia to avoid the early death. Abdominal adiposity. So this is very, very important. You have to keep your waist circumference 90 centimeters in the males, less than 90 in the males and less than 80 centimeters in the females. And of course, BMI is also very important. But in Indians, waist circumference is much more important than your BMI. Psychosocial factors is a very, very important. Your loss of stress, strain, etc. You have to love, you have to work, you have to have the passion towards your studies or your work, etc. Otherwise, these psychosocial factors also will kill you very prematurely. Increased consumption of alcohol, a moderate alcohol is good, but increased consumption of alcohol is always the dangerous. I don't advise alcoholism, but if anyone is an AB alcoholic, so better to reduce the amount of the alcohol. If you're non-alcoholic, better not to start the alcoholism. Unfortunately, in India, the consumption of the fruits and the vegetables is very, very, very low. So everyone has to take at least five times the fruits, but unfortunately, we take the fruits only when you are sick. Physical activity is very, very important. So here see not the overweight or the obesity. More than the overweight and the obesity, even the physical inactivity itself is a big risk factor. So definitely every day at least 8,000 steps or 10,000 steps or 12,000 steps. These are the very, very important to keep your heart and etc. to live for a longer period. So this slide, I think this is one of the best slides for today's talk. We have to concentrate on all these things. So no smoking, no alcoholism, more fruits, more vegetables, more physical activity, and reduce your abdominal adiposity even though you are not a diabetic and hypertensive. Even though you are a non-diabetic and hypertensive, you are at risk of getting the early death because of the other factors which are all there in our with us. We are all having the hypercholesterolemia, we are having the abdominal adiposity, we all have the psychosocial factors, and the decreased consumption of the fruits and the vegetables and decreased physical activity. So out of these, at least 5 and 6 we are all having it. So dear co-studies, so be careful about these factors to have a long and good innings. Coronary artery disease, yes, it's a major complication of the diabetes. Over 50% of the individuals with diabetes die due to the coronary artery disease, and they share a common soil for the development of the disease. The environmental factors are the common for the heart, for the diabetes, for the hypertension, like your overweight, your obesity, your psychosocial factors, reduced sleep, etc. is very, very important. See, this is the good slide, shows you the diabetes as the traditionally considered the coronary risk equivalent. So once you diagnose a person as a diabetes, definitely the risk is as equal as a patient who has diagnosed as a myocardial infarction. Suppose one fellow is discharged from my hospital with the diagnosis of the diabetes. Another fellow is discharged from the Apollo hospital with the diagnosis of acute myocardial infarction. If you follow these two cases for 10 years or 15 years or 20 years, and my patient with diagnosed the diabetes die much prematurely when compared to the fellow who has diagnosed MI today. So that means that diagnosis of the diabetes itself is equivalent to your myocardial infarction. So don't think that diabetes is a very simple disease. It is a chronic disease, it is a progressive disease, it is a dynamic disease, and it is a big killer. What are the peculiarities in the presentation of the coronary disease in the diabetes? Maybe silent, so common. So silent myocardial infarction, sudden cardiac death, these are very common in the diabetic individual. Unfortunately, the most common symptom of the coronary artery disease in diabetes is not chest pain, but it is dyspnea. So a diabetic with dyspnea, so don't think of the respiratory cause as the number one, but it could be a myocardial infarction. So all the diabetes with the dyspnea, so get the ECG done, get the troponin done, get the 2D echo done, or the angio, even all these things are the normal to rule out silent ischemic heart disease. Atypical presentations, that is the anginal equivalence, the pain in the epigastric region. So a lot of the people, they thought that the pain in the epigastric region is acute gastritis or acid peptic disease. Keep on taking the Pantocid or Gelusil, etc., etc. Finally, they die with a sudden cardiac death. So the pain in the epigastric region could be inferior wall infarction. In the same, the pain in the jaws, pain in the left shoulder, pain in the interscapular region. So these things are angina equivalent. You should consider on all the diabetic individuals as the ischemic heart disease. Occurs at an younger age. See, we are seeing the diabetes, type 2 diabetes. Yet Sri Chaitanya and the Narayana are studying the intermediate junior rector and senior rector. So because of the lack of the playgrounds, because of the lot of the stress and the strain, study out from the 7 a.m. to 7 p.m. or the 9 p.m. Lot of the people are becoming the obese and the overweight, and the blood sugars are very high, their blood pressures are very high, and they are getting ischemic heart disease at an younger age group when they entered on the Rangaraya Medical College in the final years or in the house agency or in the postgrad years. So the diabetes or the ischemic heart disease, these are all the adult diseases of the fatal origin. So I have to careful. So diagnosing today, but what about the pre-diabetes? What about the pre-hypertension? So the seeds of these diseases started much earlier than the diagnosis of your disease. May involve the small vessel selectively. Some people have the microvascular angina. If you get the coronary angiogram, so your RCA is normal, circumflex is normal, left anterior coronary artery disease is also very normal because these are all the major vessels. Major vessels appears to be the normal. What about the microvascular nature? So that is the microvascular angina. There is a diffuse and the multiple vessel involvement. So it's very difficult to put one stent or the two stents or three stents, and definitely these people are subject to for coronary artery bypass surgery. So CABG is so common in the diabetic individuals because of the diffuse disease and the multiple vessel involvement. Complications of AMI are very common, like your tachycardias or sudden cardiac deaths are so common in a diabetic and myocardial infarction. So what's the outcome following the revascularization? Even though you apply for the CABG or the PTCA, so the complications or the prognosis is not good when compared to the non-diabetic individual. So in a single word, diabetes itself carries a lot of the complications and the poor prognosis. So what are the major goals of the treatment of the coronary artery disease? So increase the coronary artery perfusion, decrease the myocardial workload, prevent the myocardial infarction, disability or the death, and intervene in cases of the unstable angina. So coming to the treatment aspects, so you have the different drugs, diabetic drugs. So diabetic drugs means not all treatment of the diabetes is not always with the drugs alone, but before the drugs, please consider the lifestyle methods. What the Kiran told just before me as when he dealing with the metabolic syndrome. So the lifestyle methods are very, very important. Lifestyle methods means 4. Number 1, your dietary approach. Number 2, your exercise. Number 3, your yoga. Number 4, your meditation. So yoga plays a major role, meditation plays a major role, your physical activity or your exercise programs plays a major role, and of course your diet. So complex carbohydrates more protein, less saturated fats, more polyunsaturated, monounsaturated fats, no trans fats, more fiber, less salt. So these are the very, very ideal things you have to change in your diet pattern so that you can give a good quality of the life. As per the drugs are concerned, you have the sulfonylureas, you have the begonides, you have the thiazolidinediones like the pioglitazone, you have alpha glucosidase inhibitors like your voglipose, and then you have the separate gliptins, sitagliptin, saxagliptin, linagliptin, teneligliptin, etc. And then you have the SGLT inhibitors like canagliflozin, dapagliflozin, and empagliflozin. Of course, you have the oral semaglutide, ribulsus, that is also there as a GLP-1 receptor agonist as a oral form. Then you have the parenteral forms as your exenatide or liraglutide or dulaglutide or semaglutide as a parenteral forms. And of course, the most important drug to be used in all the diabetic individuals is insulin. So these are different drugs available in our hand. But compared to the SGL2 and the GLP-1 receptor, these two are very, very, very good drugs as far as your cardiac safety is concerned. So to have the diabetic individuals to live for long period, to keep his vessels intact, not to have the premature atherosclerotic cardiovascular disease, the two drugs which are very important as a cardioprotective are either SGLT betas or GLP-1 receptor agonists. So these are very, very important drugs to be used in all these population. Of course, ACE inhibitors are ARBs, so they reduce the intraglomerular hypertension, they reduce the intraglomerular hyperfiltration. So they are cardioprotective, they are renoprotective, they are vasculoprotective other than your antihypertensive effects. So ACE or ARBs, they are the compelling indication to use in all the diabetic individuals when they are hypertensive. Even though they are not an hypertensive, when they are having the proteinuria, so definitely have to use these drugs because of their cardioprotective, nephroprotective and vasculoprotective effects. Finerenone, yes, that is a mineralocorticoid receptor antagonist. You have the two types of the mineralocorticoid receptor antagonists. One is steroid induced or steroid based, and the second one is non-steroid. So non-steroid is the finerenone, steroid based is your spironolactone. Now the finerenone we are using it when the GFR is less than 20 or less than the 30. So you can use the 20 milligrams or the 10 milligrams. Beta blockers, very important drugs to be used in all the diabetic and ischemic heart disease. In a single word, beta blockers are the compelling indications to use in all the ischemic heart disease because they reduce the mortality. So the mortality benefit will be seen with the beta blockers, but which beta blockers you have to use in the ischemic heart disease in the diabetic, not your propranolol or your atenolol, but it could be your carvedilol or the bisoprolol or the nebuvolol or your metoprolol. So these are called as a cardioselective beta blockers. These are the important drugs of the choice in all the diabetic individuals with ischemic heart disease. So revascularization therapy, you have the PTCA, you have the stents, you have the CABG. So you all know that now the primary PTCA. So whenever the fellow gets the heart chest pain, so immediately get the ECG done. If the ECG shows any ischemic heart disease, immediately send the patient to your cath lab. And then in the cath lab, they do the angio. And after the angio, if the single vessel disease, the double vessel disease, the triple vessel disease. If it's a single vessel disease, they put one stent. Double vessel disease, they put the two stents. The triple vessel disease, again, they can put the 3 or the 4 stents. Otherwise, the patient can be shifted for the CABG. So this is the very simple, but sometimes in the diabetic individuals, so the table deaths are also very common because of the uncontrolled diabetes, because of the autonomic dysfunction. So a lot of the people with the diabetes, they are living with the autonomic dysfunction. So autonomic dysfunction could be one of the important reasons for your hypoglycemia unawareness and also the sudden cardiac death. So secondary prevention, we use all these drugs, antiplatelet therapy, or aspirin or the clopidogrel, a combination for at least 6 months after the attack, up to 1 year, and after 1 year of your acute myocardial infarction, you can change over either to the aspirin or the clopidogrel, and then the beta blockers lifelong, your cardioselective beta blockers, ACE or ARBs are lifelong, statins are the lifelong. So here in the statins, they divide into 3 groups. One is the mild, moderate, and the severe acting or the drugs. So in all the diabetic individuals, you have to use the moderate intensity or the high intensity statins. So the moderate intensity means atorvastatin at least 10 to 20 milligrams or 20 to 40 milligrams or 40 to 80 milligrams. Otherwise, a 5 mg of the atorvastatin or 5 mg of the rosuvastatin is not useful in a diabetic individual. So the minimum statin to be used in all the diabetic individuals is atorvastatin 20 milligrams or the rosuvastatin 10 milligrams. So the primary prevention, so that means primary prevention means avoid the smoking, avoid the obesity, good sleep. These are all important steps. Suppose if the patient is hypertensive, control the hypertension. If the patient is having the dyslipidemia, control the dyslipidemia, etc. And as far as the drugs are concerned, aspirin, it's now a double-edged weapon. Aspirin is the primary prevention. So earlier we used to give the aspirin as a primary prevention. Now for the fear of the intracerebral hemorrhage, we are not using the aspirin as the primary prevention unless otherwise indicated. So this is the 10-point formula strategy for the CAD risk reduction in all the patients with the diabetes. Early diagnosis is very important. Good control of the diabetes is very important. Either your diet, your exercise, your yoga, your meditation, your OHA, your insulin, etc. Control of the dyslipidemia with your statins, high intensity or the medium intensity. So at least minimum 20 milligrams of atorvastatin or the 10 milligrams of rosuvastatin. And the patient is having hypertriglyceridemia, you can add the fenofibrate. If the patient's blood cholesterol is not controlled with your statins alone, you can add the ezetimibe. So still the cholesterol is much higher. So definitely you can go for the additional of the bempedoic acid. Also, these are all the different drugs available right now. Either the statins or the ezetimibe or the bempedoic acid or the fenofibrate to act accordingly and control your cholesterol. So the most important here is the LDL. Keep the LDL not less than 130 or 100, but at least between the 50 to 75. So very high risk individuals keep the LDL less than 55 and medium risk or high risk. So at least 70, less than the 70. So our goal is to keep the cholesterol, LDL cholesterol less than 70 or the 55. For that, you have to use the high intensity of the statins. BP control is very important. All the diabetic individuals use the ACE or ARP. Not under control, you can add the diuretic. Not under control, you can add the calcium channel blocker. Not under control, you can add the alpha blocker. Not under control, you can add the central acting drugs, etc. etc. So don't bother about the number of the drugs you are using to reduce the blood pressure, but please consider the blood pressure value. So your value of the BP is 120/80 is very important. So not the importance of the taking 5 tablets or 6 tablets, whether let him take the 5 or 6 or 7 and 8. But my interest is let his BP be there at least to less than 130/85 or 120/80. Aspirin were indicated. So I told you the primary prevention. Now the big dietary modification is very important, especially for our Godavari people. So I have a lot of the functions and etc. And each place is costing about 3,000 rupees, 4,000 rupees, 70 items, 120 items, etc. So definitely the dietary modifications are very important for all of us. Exercise is very important. Weight reduction is important if you are overweight or the obese. Quit smoking is also important. See here the weight. So don't think that our normal BMI is 25. For Asians, for Indians, the normal BMI is 23. So if the 23 is the normal BMI, I think that 80 to 90% of the people assembled here, we are all having the BMI of more than 23. My BMI is 26.6. You can imagine that I am overweight, not overweight, I am obese, according to our Indian standards. So you have to reduce the weight. This is very important. Quit smoking in any form and relaxation techniques like your meditation, etc. So if you follow this 10-point formula, all our diabetic individuals live for the longer period. But it is very easy to say, but very difficult to practice. Heart failure is very important in the diabetes individuals. So big thanks to our interventional cardiologist. Now we are sending the patient for the acute myocardial infarction. So next day he is very happy because 1 or 2 stents are CABG. And he is living for another 10 years or 15 years. To what? To get the heart failure. In the same way, now the creatinine level is 7.5 or 9 or 10. We are sending to the nephrologist. So he is putting on the dialysis and then planning for the transplantation. Good. He is living for another 15 or 20 years. For what? To get the heart failure. So the heart failure in India is so common because of the 4 causes. 1 is ischemic heart disease, 2 is diabetes, 3 is hypertension, and the 4th is the overweight or the longevity. So unfortunately, unfortunately, now the average age is increased. So that is the reason we are seeing a lot of the heart failures in the society. So you have the systolic heart failure, you have the diastolic heart failure, etc. So again, the diabetes, breathlessness, etc. You have to rule out the ischemic heart disease, but also you have to rule out the heart failure, the fatal edema, puffiness of the face, your elevated JVP, hepatojugular reflex, ascites, fatal edema, etc. orthopnea, PND. So definitely it's almost any fellow, even undergraduate also can diagnose the heart failure. So diagnosis of heart failure is not a big problem, but the management is very important because hospitalization is so common in the heart failure, and the mortality in the hospitalization is also very common in the heart failure population. So the management again here, the metformin in the heart failure, big contraindication because hypoxia that causes the diabetic ketoacidosis or lactic acidosis. Sulfurious in heart failure, no, because they cause the hypoglycemia. Again, hypoglycemia precipitates the heart failure. Insulin, yes, when the fellow's blood sugars are very high. GLP-1 receptor agonists, so may be used and may not be used most of the times. But the one important drug to be used in all the heart failures is SGLT2 inhibitors. So that is the reason SGLT2 inhibitors now is almost like a cardiologist drug. Whether the fellow is a diabetic or non-diabetic, this diabetic drug being prescribed for all the diabetics and non-diabetics when the fellow is having the heart failure. Now we have the 4 pillars in the management of the heart failure. One pillar is your ACE or ARB or ARNI, that is your valsartan and sacubitril combination. And the second pillar is the mineralocorticoid receptor antagonist, either spironolactone or the finerenone. And the third arm is your beta blockers, that is cardioselective beta blockers, like your carvedilol or bisoprolol. And fourth pillar is SGLT inhibitors. So the SGLT inhibitors are very, very important drugs to be used in all the heart failures in the diabetes. So now moving to the peripheral vascular disease, it's so common, lot of the vessels are involved here, but this is very common in the smokers. So diabetes and smoking, so definitely the more and more chance of having the peripheral arterial disease. All the peripheral arteries, your iliac or femoral, popliteal, subclavian, etc. These are all the risk factors in the diabetes, hypertension, dyslipidemia, cigarette smoking, and the renal disease. So in all the diabetic individuals, you have to treat A, B, C. A stands for A1C, that is your diabetes management. B stands for BP, so to keep the BP as close to the normal, and C stands for the cholesterol. So if you control ABC in all the diabetic individuals, I think no diabetic will develop any complication in the future. So A1C, your blood pressure, your cholesterol. And of course, D is also very important, that is your dietary approach, your doctor's advice, etc. And E is also very important, that is your exercise. So ABC and D is diet and exercise, you have to add it. So definitely all the diabetes will live for the 100 years. Difference in the diabetic and the non-diabetic peripheral arterial disease is so common. So you see that toe here, very common in our population. So there is a dry gangrene because of the blockage of your dorsalis pedis or the pedal vessels. Diagnose the ankle brachial index, so less than the 0.9, more in chance of peripheral arterial disease. See here the management of the peripheral artery. We have the selastojol, that the peripheral vasodilator used in some patients. But finally, thanks to the interventional vascular surgeons, so now when the fellows, these Doppler is done, when there is a blockage, they put 1 or 2 stents here, again like your ischemic heart disease. So that's how we have to treat the peripheral artery. So peripheral artery disease means cessation of the smoking and good ankle brachial index, you have to keep it more than the 0.9, and then selastojol as the medical management or the surgical management if needed. Cerebrovascular disease, stroke is so common. So you have the major and the minor evolving stroke and transient ischemic attacks. So the symptoms depend on the vessel involved, your posterior artery or the anterior cerebral artery or the middle cerebral artery. Hemiplegia is so common with the middle cerebral artery, and the antecerebral artery, posterior cerebral are also very important. These are all the risk factors. Again, hypertension, smoking, diabetes, dyslipidemia, etc. So diagnosis, CT scan is very important. Without the CT scan, so the diagnosis of the stroke, the cause for the stroke is very, very difficult. It's so arousable, is conscious and the coherent, but the stroke cause, it could be hemorrhagic stroke. Suppose if you thought that the patient is cerebral ischemic stroke and start giving your aspirin, the clopidogrel, you are killing the patient. So CVA in the diabetic individuals to rule out either ischemic stroke or the hemorrhagic stroke. So definitely the CT is very, very important. So in all the infarcts, we use the aspirin, the clopidogrel, and hemorrhage, we don't use it. So the primary prevention, so control that risk. Secondary prevention, these things, tertiary prevention, endarterectomy and the stenting. So now the interventional neurologists are available, interventional neurosurgeons. So they do the carotid endarterectomy and the stentings. So there are the different cells. Now the diabetic kidney disease. So the diabetic kidney disease is a very, very common disease. So unfortunately, a lot of our diabetic individuals, they are having the proteinuria. We don't recognize the proteinuria. We don't give respect to your microalbuminuria. So if you get the microalbuminuria, if you read the urine proteins, so once the fellow is having the proteinuria, that is the time you have to start the ACE or ERPs. So unfortunately, we are not doing that, and we are keeping the diabetes for another 2 years or 3 years only to elevate his creatinine levels. Once the creatinine levels are elevating, then the quality of the life starts reducing. So these people will have the nausea, will have the vomitings, will have the anemia, will have the osteoporosis, will have the renal osteodystrophy, etc., etc. And they invite a lot of the infections, especially pulmonary tuberculosis and etc. So that's how the diabetic kidney disease occurs in all the diabetic individuals. The magnitude of the problem is very, very common in our society. It is the leading cause of the end-stage renal disease. So these are all the risk factors. Not only your diabetes, your hypertension, your duration of the diabetes, your family history of the diabetes, ethnicity, smoking, lipidemia, analgesic use. This is very common in our society. Unfortunately, most of the medical shop people, they give NSAIDs for everything. So a lot of the diabetic individuals, they use the analgesics for a longer period only to kill their kidneys. So these are the staging according to the GFR. You stage the CKD when the GFR is between 90 to 100 is the stage 1, 60 to 90 that is the stage 2, 30 to 60 is the stage 3, 15 to 30 stage 4, less than the 15 is stage 5, and very little can be done when the stage 5. Again, unfortunately, a lot of the people, even at the stage 4, they are asymptomatic. So that is the reason all the diabetic, don't be happy with the blood sugar. At least you get the urea creatinine, at least creatinine levels once in 3 months or once in 6 months, once in a year to rule out your diabetic kidney disease. Otherwise, these people are asymptomatic till they enter the stage of stage 4 or the stage 5, where very little can be done except advising them to go for either transplantation or the dialysis. So urinary microalbuminuria is a very, very important. Urinary albumin creatinine ratio, UACR, spot test. Within 5 minutes you get the result. Less than the 30, normal, 30 to 300, it is a microalbuminuria. More than the 300, it is a macroalbuminuria. More than the 500, it is the proteinuria. More than 3.5, it is an nephrotic range. So this is the chart. On one hand, you have the proteinuria. On the other hand, you have the CKD, that is your GFR. So accordingly, you see that. If you see here, only the 2 things are there. 2 points are there for the green. All others are either yellow or the red or the dark red. That means only 5 to 10% of our diabetics are the normal population here. Lot of the diabetics, whether the proteinuria starts or when the creatinine levels goes up, they are at high risk or very, very high risk. So the treatment of the diabetic kidney disease, control the blood sugars, control the blood pressure, control the lipids. I told you ABC. So ABC holds good for all the complications of the diabetes. If you concentrate on the ABC and also D and E, I think 95% of the diabetes will live for the longer period. See the diet control, your SGLT inhibitors, though they are renoprotective, they are vasculoprotective, they are cardioprotective, and of course RAS blockers. So in all the diabetic individuals, they need RAS blockers and also the SGLT inhibitors unless otherwise contraindicated. So the renal failure and anti-diabetic drug therapy. So when the fellow is in the renal failure, we have to use the very, very few OHAs. Metformin, no. According to the GFR. GFR less than 30, don't use it, stop it. More than the 60, use it, 30 to 60, reduce the dose of the metformin. Sulfonylureas, longest sulfonylurea is a glibenclamide, very contraindicated. Shortest sulfonylurea, glipizide, that can be used in the Udanu area where a lot of the people are having the CKD. Suppose if you want to use the sulfonylurea, so glipizide is the better in the renal failure. Thiazolidinones, no, because they cause fatal edema, they cause anemia, they increase the body weight. And the gliptins, all the gliptins can be used in the renal failure. But if you take the renagliptin, so that can be used without any dosage adjustments, whereas other gliptins you have to adjust the dose according to your GFR. SGLT inhibitors can be used in the renal failure till your creatinine level is 2.5 or 3 or the 4. And if you see the GFR after the 30, you can use the SGLT inhibitors, and less than the 30, you have to stop it. But one drug which can be used in all the people of the renal failure is your insulin. But most of the diabetic individuals, when they are in the renal failure, they invite a lot of the hypoglycemia. So all these years, the patient's blood sugars are very high, but the last 2 months or the 3 months is getting the hypoglycemia, means the one test you have to order immediately is your creatinine levels to rule out the renal failure. So once the fellow is in the renal failure, there are high chances of having the hypoglycemia. So you know how the SGLT inhibitors acts. So you have all the glucose is filtered by the glomerulus, and all the filtered glucose is again reabsorbed from the proximal convoluted tubule. So by using these SGLT inhibitors, you are blocking the reabsorption of the filtered glucose. So what are all the filtered glucose is there that will be enter into the loop of the Henle and then the distal convoluted tubule and then the urethra, etc., and they pass on. So in a single word, you are causing therapeutic glucosuria in these people when you are using the SGLT inhibitors. If you check the urine sugar, when the fellow is on the SGLT inhibitor, so urine sugar will be 4+. So you are causing the therapeutic glucosuria. So that is the reason when the personalizing is very poor in the rural Indian population. So when you are starting on the SGLT inhibitors, the chances of the urinary tract infections and the mononal infections are very high because of the extensive glucosuria in the kidney, in the urinary tracts. Retinopathy is again very, very important. Retina and kidney are very close friends. So when the fellow is having the diabetic kidney disease, so the one investigation we immediate order is the check the retina. In the same way, when the fellow is having the retina either non-proliferative or proliferative diabetic retinopathy, again another test we advise is definitely get the urea, creatinine and electrolytes to rule out your diabetic kidney disease. So these are the very important drugs. See the fundus here, how bad they are. Proliferative diabetic retinopathy, diabetic macular edema. See, this is a normal retina. I think only the 5 to 10% of our chronic diabetes will have the retina like this. If you see the retina in all our diabetic individuals, they are having either the non-proliferative or the proliferative diabetic retinopathy. See, these are all the hemorrhages, dot and hard hemorrhages, and the soft exudates. See the hard exudates, venous changes. See the proliferative diabetic retinopathy, macular edema. Very little can be done at this juncture. So one of the important causes of the blindness in India is not only your cataract, but also your diabetic retinopathy. So the take-home message for all of you is all the diabetic individuals, you have to send them for a retina examination to an ophthalmologist. You have to very clear. So see the retina because the patient to rule out the diabetic retinopathy. Otherwise, they do the refractive error and your glasses is okay. You are not having any refractive error, etc., etc. So when the fellow is a diabetic, when you are referring to an ophthalmologist, be specific that to rule out the diabetic retinopathy. Dear doctor, please examine this patient to rule out diabetic retinopathy. So whether the patient is having the diabetic retinopathy or not, if the diabetic retinopathy is there, whether it is a non-proliferative or the proliferative, etc. So the laser therapy, see how the funduses are very bad. Now the neuropathy is the most common complication of the diabetes in Indian population. Most common complication is the neuropathy. Unfortunately, very difficult to diagnose it. Most of the times it is only symptomatic. Most of the times it is objective, not the subjective. See the most common and the most troublesome of all the diabetic complications. More than the 50% of the patients will have the painful complication. Sometimes these people also have the secret complication, that is your erectile dysfunction in young diabetic individuals. See the diffuse neuropathy, a mononeuropathy, radiculopathies, etc. Diffuse symmetric polyneuropathy is the most common, the tingling and numbness sensation, paresthesias. See the wasting of the introsea here, the hamartosis, that means motor neuropathy. But the sensory neuropathy is very common. The motor neuropathy is so common, those people who are living barefooted. See the toe ulcers, callus formations, etc. They are the root of the infections. Cranial nerve neuropathies, so common. Cranial nerves, thoracic nerves, peripheral nerves. See the third nerve palsy, sixth nerve palsy. Diabetic amyotrophy, proximal motor neuropathy is very difficult to get up from the sitting position. So they have the motor neuropathies here. So this is the monochrome filament, 10 grams monofilament, the Siemens filament. You have to see these areas to rule out your peripheral neuropathy. And management of the neuropathy again ABC. Glycemic control, your diabetes control, your cholesterol control, some symptomatics. Painful neuropathy is very difficult to manage. So we use a lot of the drugs here, your methylcobalamin, your pregabalin, gabapentin, etc. But no single agent is universally effective. Most patients require the combination therapy. And again, we invite a lot of the side effects of these pregabalin, gabapentin, etc. So they present with pedal edema, they present with disorientation, they present with nightmares, they present with sleep disturbances, etc. They are not the very good drugs to be used, but we are forced to use these drugs because very few drugs are there for your painful neuropathy. So DKA is a very common, it's acute metabolic complication. So DKA means 3 diseases here. D stands for your high blood sugars. K stands for your ketosis, that is urine ketone bodies will be positive. A stands for your acidosis, your pH will be less than 7.4. So this is the very important. Any fellow, a diabetic individual present with severe dehydration. So definitely please think of diabetic ketoacidosis, get the blood sugar done, get the urine ketone bodies done. Urine ketone bodies 4 plus, 3 plus, traces, etc. The blood sugars are 400, 500, 600. You are dealing a case of the DKA. Only 2 drugs you are supposed to give. One is the normal saline, the second one is the insulin. Why I am saying the normal saline number 1? The normal saline because the patient is the dehydration. So give rehydration by giving the normal saline and then start giving the insulin. So mild, moderate, severe. So accordingly, we get the pH, we get the bicarbonate, we have the urine ketone bodies, we have the blood glucose, etc. To divide them the mild, moderate, severe. So only to consider the patient. So whom to be shifted to the ICUs, whom to be shifted in the wards or in the rooms. So the mild can be easily treated in the wards or in the outpatient, but the moderate and severe, they need admission in the ICUs. So insulin is very important here. No OHS in the diabetic ketoacidosis. No OHS. Stop all OHS. Start insulin only. Again, in the insulin, don't give the mixed-start or the long-acting insulins or the basal insulin. Give always a regular insulin, a short-acting insulin. So a lot of the electrolyte deficits, you have the sodium deficit, chloride deficit, potassium deficit, calcium, phosphate, and magnesium, and act accordingly. Complications. So fortunately, nowadays we are not seeing a lot of the much complications the DKA because of our early identification of the problem and early initiation of the normal saline therapy and early initiation of your regular insulin. But some people with the diabetic ketoacidosis, they develop ARDS, they develop sepsis, they develop cerebral edema, so they develop acute kidney injury, they develop other complications. They are all life-threatening complications. So don't think that DKA is a simple disease, but it's a very big disease. Left untreated, and definitely the people is going to die with all these complications. HSS, fortunately, we are not seeing high cases of the HSS, but it's very common in the elderly individuals who are living alone. So these are the precipitating factors like the infections, severe stress, so physical or emotional. Now, a lot of the people are staying in the old age homes at the age of 70 plus, 80 plus, and there is the history of the diabetes for the last 30 years, 40 years, 50 years. So here in Kakinada, we have the 4 or 5 old age homes, and 50% of these old age home people are diabetics. And if you take the average history of the diabetes in them is more than 25 years or 30 years. So those are the ideal candidates to get the HSS when they are having the lot of infections, when they are having the psychological stress or the emotional stress, etc. So the 4 primary features here: severe hyperglycemia, the blood sugar will be 600, 700, 800, whereas in DKA, 250 mg is sufficient to cause the DKA, but in HSS, the blood sugar is usually more than the 600. Absence of the ketosis. The ketone bodies will be negative in spite of very high blood sugars. Think of HSS. Profound dehydration. Dehydration is much more than the DKA in HSS. And neurological manifestations, they are confusable, etc. So again, in the treatments, you have the fluids and of course the insulin. So there's some differential points among the hypoglycemia. Is a very, very important complication of the diabetes. It is a Whipple's triad. The people presents with the symptoms of the hypoglycemia. You know the adrenergic symptoms and the neuroglycopenic symptoms like tachycardia, palpitations, etc. And then document this low blood sugar with your glucometer examination, and then immediately give some biscuits and some sugar, etc. And the patient blood sugar will go up, and then he will be devoid of all these symptoms. So that is the beauty of the hypoglycemia. So hypoglycemia is so common, and if you identify the hypoglycemia, and if you document the hypoglycemia, and if you introduce the sugar either orally or the parenterally when the patient is in the comatose condition, and definitely the results are very, very, very good. So these are all the symptoms and the signs, the sympathetic and the neuroglycopenic. Hypoglycemia unawareness is very common in elderly individuals, people with autonomic dysfunction. Nocturnal hypoglycemia is so common. So if you left untreated, these people, most of the people, they die with a lot of the perspiration and lot of the sweating. And we thought that he must be dying, he must have died with acute myocardial infarction. But that is not the reason. He died of hypoglycemia, nocturnal hypoglycemia. So that is the reason. In elderly individuals, don't keep the HbA1c at 6.5. Don't keep the fasting blood sugar at 100. Don't keep the post-mortem blood sugar 150. Hey, relax. So fasting blood sugar may be 130, or post-mortem blood sugar may be 220 or 230, and HbA1c may be 7.5 or 8. So those are the targets in the elderly individuals, and very to avoid the hypoglycemia in them. Thank you very much for your patient hearing.